Welcome to our Counselor in Training orientation. My name is Desiree Cochran Norfolk. I am a certified master addiction counselor through the Georgia Addiction Counselors Association, which is a subsidiary of NADAC. I have a master's in addiction counseling. I'm also a certified anger management specialist. What we're going to be talking about first is the NADAC Code of Ethics. So we're going to go through the different principles so you get a general idea, and then we'll go through the GACA Code of Ethics as well. They're kind of the same, there's just a couple differences here and there. So the first principle is the counseling relationship, and then we'll talk about confidentiality and privileged communication, professional responsibilities and workplace standards, working in a culturally diverse world, assessment, evaluation, interpretation, e-therapy, e-supervision and social media, supervision and consultation, resolving ethical concerns, and research and publication. So principle one is about the counseling relationship. So this involves client welfare, making sure that the client is taken care of, informed consent. So we want to make sure that we are giving the client all the information that they need. This includes how much they're going to be paying, what's the limits of confidentiality, um, what are their responsibilities, their rights, etc. We want to give them all the information that they're going to need. When we talk about limits of confidentiality, what we're talking about is what we are and are not allowed to divulge to other people based upon what they're telling us. So, according to the NADAC Code of Ethics, we have certain areas where we have to report. We are considered mandated reporters. So if someone tells us that there is some sort of child abuse or elder abuse, we have to report that. And you can discuss that with your client and let them know up front, hey, if you tell me these things, I have to report it. And then if there is some sort of instance, don't do it behind their back. Let them know, hey, I have to let DFACS or CPS know that this is going on. I will walk you through it, etc. And you can actually make the phone call with them. Also, if there's any report of self-harm or suicidal or homicidal ideations, we have to break confidentiality at that point. We talk about diversity in the Code of Ethics. You're going to have a diverse group come to you. So it's important to have an understanding of different cultures and different races and how they interact with counselors and how they're assimilating into their cultures. It's very important that we have this understanding, and so taking courses on multicultural counseling is advised. The Code of Ethics covers discrimination. So we can't say, no, we're not going to treat you because we don't like people like you. This includes ageism, sexism, race, class, anything like that. We're not allowed to discriminate in treatment. And then we have a legal competency to really just know what we're talking about. So having the education, having the certification, um, that's important that you actually know what you're doing. I can't say that I'm a marriage and family counselor if I'm an addiction counselor. I can't do marriage and family counseling. I can't prescribe medication if I'm not a psychiatrist. So having that legal competency is important. And then we talk about mandated versus unmandated clients. So research has shown that even if they are mandated or not, just being in the groups or in counseling itself is going to benefit them as opposed to have never gone to treatment before. So dealing with mandated clients, we're going to deal with a lot of resistance. And so learning to roll with that resistance. Also, When we deal with mandated clients, we have to know that we cannot give their information out to anyone. That includes their mama, their sister, their brother, their cousin, their friends, aunties, their probation officers, their attorneys. We cannot do that unless we have a written consent form. And we call these ROIs, or release of information. And we typically just have a client sign that if we know that we're going to be sending over information to their attorneys or their probation officers or the courts, their jobs, whatever. We want to make sure that we have that in writing, um, because if you don't write it down, it never happened. And then we talk about having multiple therapists and having the ability to talk to the other therapists about the clients. We have the right to do that as part of the confidentiality. You can talk to your supervisor. You just want to limit the amount of information that you are giving to people when you are asking for help, maybe with a situation. So, more on principle one in the counseling relationship, it's going to go over boundaries. So, I'm not allowed to go out and uh, get my car washed. And that kind of ties in with the multiple and dual relationships. I can't have one of my clients wash my cars. Now, there is a clause in the Code of Ethics that says that you can do some sort of bartering system for your services for the client, but that's kind of pushing into that multiple dual relationship. So I would caution you to just steer clear of it altogether. It becomes mucky and muddled. You can't have sexual relationships or romantic relationships with your clients. They can't work for you. You can't have your car serviced by them or whatever. So having those dual relationships, you need to steer clear of that. And in some codes of ethics, it says a certain number of years. NADACs, it's ever. So you can't have a sexual relationship with a client ever. Um, it talks about having prior relationships. You really should steer clear of counseling relationships if you know someone from your past. This includes family and friends. They often will come to you for counseling and you'll just have to refer them out. It's it typically doesn't work out when you try to counsel a friend or a family member. They don't listen. Um, it talks about previous clients and group financial disclosure, disclosing to the client what their actual true costs are going to be upfront. And how are you going to communicate? Are you going to communicate through text message, phone calls, emails, and are these protected through HIPAA and secure? And how much communication are you going to allow your client to have with you? Are you going to be 100% accessible? Are you going to have some sort of boundaries to that? These are my office hours. So you need to discuss that with the client as well. And then also treatment planning and doing this in collaboration with the client. So when you are coming up with a treatment plan, you don't just want to tell the client what they're going to do. You want to make sure that it's something that the client also agrees to and helps you to form. It talks about documentation. Again, if you don't write it down, it never happens. So document, document, document. Write it down. Write down everything, all your notes, put it in their file. But also keep in mind what you are writing down because the client can have access to this if they request their file. So you don't want to write anything detrimental in there that could interfere with the client's progress. You also have to keep in mind that in addition to the client having access to the record, if the records are subpoenaed, you don't want to put too much information into the file that can be used against the client. And then it talks about advocacy. So we are advocates for our clients and our communities as a whole. So we are expected to advocate on our clients' behalf. So if there is some sort of injustice going on, we are expected to advocate to fix those injustices. Referrals, we're not allowed to be paid for referrals. If you refer someone to someone else, you can't receive compensation for that. Um, Referrals are a good thing, though. If you feel as though you're not equipped to help this client, a referral out may be the best thing for the client. So, keeping in mind that maybe this client has some mental health issues that you're not equipped to handle, referring them out to another therapist. Or if the client has some sort of sexual addiction issues, referring them out to a therapist that deals with that type of thing. If a client has addiction issues, referring them out to an addiction counselor. These are the things that we refer out for. Um, or maybe you and a client are just not clicking or clashing, it's detrimental to the client's health and well being, then you would refer them out to a different counselor. Um, Not exploiting the relationship, not having sexual relationships, also discussing termination from the very beginning. So, even from the beginning, we want to know this is not indefinite. You're not just going to be here for the rest of your life. There's got to be something that we're working toward. What are the goals? And that's part of treatment planning. Figure out what those goals are and determining what are the markers for reaching those goals. And once we've reached those goals, then you no longer need this counseling relationship. And if they do continue forward after they've met the goals, then they're using the counseling relationship as a crutch. So we need to discuss termination from the very beginning. That is a test question when you go to take your test for your CAC1 or CAC2. When do you start talking about termination? From the very beginning. And then coverage. What areas do you cover when you do treatment? And abandonment. Okay, so you can't just say, oh, I want to go out with my girls this weekend, so I'm choosing not to do my therapy sessions. I'm just going to reschedule. Um, we we're not allowed to do things like that. So making sure that there's someone to cover for you if you do get sick or you can't do your treatment, having someone to step in, having a team that can handle this sort of thing. You can't just abandon your client. You have to discuss with them beforehand, do a referral, sit on the phone with them. And when we do referrals, just a side note, don't just hand them a piece of paper and say, here you go, this is who you need to go to. Make the call in front of the client or with the client on the phone. Make the phone call, get them scheduled for an appointment, and then follow up with the client to make sure that they actually went to the appointment. And then when we discuss fees, the client, it needs to be reasonable, obviously, but the client needs to know what the fees are up front. No surprise fees. And then when we talk about collections, we're not allowed to deny the client access to their records if they haven't paid. Um, and then going after a client for financial recompense is discussed in the Code of Ethics, so it would be worthwhile to read the Code of Ethics. You kind of get into some muddy waters there. Self-referrals, this just means that clients are referring themselves, they're not coming from anybody else. When we talk about commissions, so we cannot take commission off of referrals. It talks about enterprises, withholding records and reports, we can't do that. It talks about disclosures as far as the payments goes, and you have to do the counseling regardless of compensation. Unfortunately, this is one of the fields that says, hey, if they can't pay, you still gotta work. So it's all about the client's mental health and what's going to be best for the client's mental health. If they can't pay, work out something else with them. And then billing for actual services, keeping good financial records, and then suspension of services. is all discussed in the code. And then it talks about unpaid balancing or unpaid balances and bartering, accepting gifts, which we're not really allowed to do. Small gifts that are inconsequential, like a client brings pizza to the group or hands you a piece of candy. If there's no significant amount, dollar amount attached to the gift, then the Code of Ethics says you can accept it. However, I would steer clear of that. You never know what a client's intentions are. Um, so, my theory behind that is I just don't take anything, especially food and drink. There was a student once that was the teacher's favorite student, and she brought her a coffee every morning. And apparently, the student had been poisoning the coffee with antifreeze, and the teacher got so sick and was unable to work ever again. She was mentally handicapped at that point, and it was all from her favorite student. So, even if you feel as though you're good with the students or the clients, I just I would steer clear of taking food and drink from clients or accepting any gifts. And I just let them know that up front. Hey, I can't accept anything. It's very thoughtful of you. However, I can't accept gifts from you. And then uninvited solicitations. And then it talks about virtual whatever. So technology and what are the parameters of that and dealing with over the phone, over the internet. There's so many different methods of communication these days. Um, so dealing with virtual counseling relationships is its own course, and you can take telemental health to kind of navigate through those things. In Principle 2, we talk about confidentiality and privileged communication. So the documentation is all confidential as well as what's said to you as a counselor. Everything is confidential. We are not allowed to disclose any information to anyone else without a written informed consent. That includes the documentation. Um, who has access to the documentation or the client's record? So this is going to include you, your supervisor, your clinical supervisor, and anybody else on the treatment team may have access to the client's records or the client's information, um, or anybody you're consulting with. If you are consulting with somebody, even with a supervisor, you do want to limit how much information is divulged to someone else, even a supervisor or a clinical supervisor. What can you share? So again, take out as much identifying information as possible. So you can't say the 6 foot tall guy that I'm working with, and there's only one 6 foot tall guy. Just say a male client that I'm working with has this problem if you're discussing it with a supervisor or a clinical supervisor. How much can you disclose? This is discussed in the Code of Ethics. And again, I'm just doing a rough overview today. You really do need to read through the Code of Ethics, learn it, live it, breathe it, understand it, because they can ding you pretty hard if you violate one of these ethical codes. Privacy, confidentiality, privacy is number one. It's a HIPAA law. It's a federal law that we have to abide by, where we cannot give access to anyone's records. So keeping records in a locked drawer in a room that has a door that locks, that's important. Not disclosing the information to other people, using HIPAA compliant ways and means of communication, etc. And then we already talked about the limits of confidentiality, but it kind of goes into further detail in the Code of Ethics. And then we talk about imminent danger. So if the client is in imminent danger of harming themselves or someone else, we do have the duty to report. Now, This does not mean that we have the duty to tell the police officers that our client said they were going to kill someone. We don't have that duty, but we do have a duty to protect. So it's called the duty to warn. So we can somehow prevent the client from harming someone else by having them put into observation for a 48-hour period or something. We have the duty to warn. Going further in this second principle of confidentiality and privileged communication, it talks about what is available to the courts, only putting essential items into the file, multidisciplinary care. So, one person has addiction and mental health, another person may have addiction, mental health, and sex trauma that they need to work through. So you're going to have different disciplines working in a team to care for this one client, and communication between those therapists or counselors is key. It talks about different locations, what's required in those locations, who's going to pay, making sure you encrypt your data, and even the deceased parties are protected by HIPAA. And then it talks about all parties and minors or others who may or may not be able to give legal consent, and they are allowed to give consent or not give consent to give out information, and we should honor that. But at the same time, we do have a duty to report to the parent. And just because someone's paying doesn't mean that they have access to the client's information. So it talks about how to store and dispose of documents. You want to make sure that you're shredding all documents that have confidential information on them and storing them for a period of time. We do it for 6 years. Some places do it for 5, some do it for 7. Video recording. Now, you may have to record your sessions for your supervision or for whatever reason. You may do video recording of sessions. You want the client's consent, full consent, letting them know what you're doing with that video and what purpose it's for, who's going to be watching it, etc. Recording any e-therapy, it's the same thing. Federal regulation stamps, transferring records. So if you're going to transfer a record, there has to be a release of information with the client's signature on it before you release any records to anyone else. You have to have written permission. Multidisciplinary consultations. Again, this goes back to the treatment team and consulting with each other and just having open communication. And health status is protected, so you can't tell someone else if there is an HIV case or whatever. You're not allowed to give out a client's health status to someone else. And I saw this actually happen in an inpatient facility where one client had been diagnosed with a certain disease that could be sexually transmitted. And there was another client who was sexually interested in that client. And so instead of giving out the health status, I just discouraged the male client from pursuing the relationship further. And I discussed it with the female client for her to be open and honest about her diagnosis. But I'm not allowed to tell the male client that the female client has a sexually transmitted disease. So again, it talks about storage and disposal, it talks about termination and consultation with someone on your team or someone outside of your team. Again, limiting the amount of information that you give out. So now we move into principle 3, which is the professional responsibilities and the workplace standards. So what are your responsibilities? And are you living up to this word integrity? Doing the right thing even when nobody's watching. making sure you're not being discriminatory towards any clients, making sure you're not committing fraud. I've seen that happen. Um, Making sure you're not in violation of any ethical codes or any legal mandates. Definitely making sure that you're not harassing anyone and keeping your memberships up to date. Making sure you have the right credentials and you're not saying, oh, I'm a CAC2 when you're actually a CAC1, or you're not claiming to be a marriage and family counselor if you don't have proper credentials for it. Um, Making sure that your references are accurate. So for me, I am a master addiction counselor, but there is a certification that would make me be a master addiction counselor. So I have a master's in addiction counseling, but I am not a master addiction counselor. If that makes any sense, there is a separation of it. So I need to make sure that my reference and I'm representing myself accurately, um, and staying within your scope of practice. So I am not a marriage and family counselor, I am an addiction counselor. So I need to stick with addiction counseling. I can't just read an article about marriage and family counseling and then say, "Oh, I'm certified in that." I'd have to actually go and get certified in that, get my license, make sure that I am staying within my scope of practice. Staying within my boundaries of competence. So again, I'm not competent in delivering XYZ treatment program. So I'm not going to deliver XYZ treatment program until I've been trained on that. Making sure you're proficient in what you're doing. So education is key here. Educational achievement. We want to continue our education even though we've already got our degree or whatever. We are required to continue taking courses in the community, which are called continuing education units, um, toward our recertifications every year. So, or every 2 years, every 3 years, whatever it is that you're going for, you have to have continuing education units. Monitoring yourself, making sure that you're on track, you're not violating any laws or ethics codes, and using scientific research based methods. So, not just going off and trying something that you're like, oh, maybe this will work. Using something that's already been shown to be effective in treating these clients. Using the most innovative technology, the innovative treatments, making sure that you're competent in multicultural counseling, and then again with the multidisciplinary care, other medical professionals, being collaborative with all of the people on the treatment team, making sure you're professional, making sure you're qualified, and then again it talks about advocacy here for professional responsibilities, and advocacy for workplace standards. Make sure that you have the knowledge that you need to go forward. And then it talks about organizations versus private practice and what are the responsibilities and the standards for those. Not making any public comments on behalf of NADAC, and then developing your professional skills and standards, making sure you have the right policies in place, making sure you're not impaired while you're at work, so taking medications, drinking, using drugs, those types of things. And then it talks about referrals. You also want to make sure that you're going over termination, representing yourself accordingly. It talks about promoting yourself, using testimonials, what reports that you're going to need, and getting advice. Making sure you don't have dual relationships with clients professionally, and making sure that you are not doing anything that is illegal. Also, you need to make sure that you are under supervision until you have enough certification to where you don't need supervision anymore, and giving credit where credit is due, especially when you're writing or presenting something, you want to give credit where you got the information from. Now we move into principle 4, which is working in a culturally diverse world. So you want to make sure you're respecting the client, respecting their culture, understanding their cultures and their personal beliefs, where they came from, understanding their heritage, and giving them credibility. So you may not agree with something, however, that may be part of their culture and their heritage. So just understanding that it is credible. Understanding the roles in the different cultures. So in some cultures, the female is the head of the household, and in some cultures, the male is the head of the household. In some cultures, the woman is supposed to take care of the man. In other cultures, the woman works alongside with the man and or one, and they work together in a relationship. And understanding the methodologies that go along with each of those cultures. What's going to work for some cultures? Some cultures, they don't like group therapy. They want to do one on one individual therapy. Other cultures, it's shameful for them to seek therapy. So they may miss your sessions. And it's not a lack of commitment on their part, it just may be part of their culture or their heritage. And this is where taking a multicultural counseling course can really help you to understand. And then again, advocacy for culturally diverse workplaces, recruiting a culturally diverse staff, making sure that you are able to accommodate anybody with special needs or any culturally driven needs. Then we talk about principle 5. So this is where we discuss assessment, evaluation, and interpretation. So making sure that you're using the right assessments. Are they valid? Are they reliable? Have they been tested? And then understanding it enough to explain it to the client. It talks about administrative things that you may have to go through as far as documentation and keeping the files and so on and so forth. What cultural influences are there on assessments and evaluations? So is there a language barrier? Is this even going to apply to the Hispanic culture? Is there a separate test that could possibly benefit someone from a Hispanic background or an African American background or a Pacific Islander background? Has it been shown as reliable for these particular cultures? And then, of course, it talks about diagnosing and making sure that you are diagnosing properly, um, not misusing the results, but just taking them into consideration. If the results are not normal or not normed, um, and then it talks about referral, security, forensic stuff, and dual relationships. Now, principle 6 is about e-therapy, e-supervision, social media, etc. Um, Basically, you just want to keep your account on private. You don't want to be friends with your clients on social media. Um, you want to be competent in using these different telemental health services that are out there. Are they HIPAA compliant? Making sure that the client is aware that this is how you might be communicating with them. So that's part of the informed consent. Being competent in the technology that you're using, making sure you're not breaking any licensing laws or state and federal laws. Again, is it secured? Is it HIPAA compliant? Does the client have access to it? I know in rural Georgia, there are a lot of clients who don't have internet access. So e-therapy might not be their best form of communication with their therapist or their counselor. So does the client have access? And then how is it transmitted? multidisciplinary care through telemental health. Are you sharing information with other counselors or disciplines? And then what are the local resources? What are the boundaries to their treatment through e-therapy? What are the capabilities of the e-therapy? And I will tell you, since COVID started and we started using more telemental health, it is very difficult to do process groups online using the video and audio. It's so much different than being face to face. So you may miss cues, like if the client is muted and you can't see their face, then you may not see that they're tapping their foot, or you may not see them, glance away or frown when you say something. So missing cues is a big part of telemental health that you have to be prepared for and stay on top of. Make sure that your client is in the video and you can see them. And then, of course, maintaining records. Electronic records are the thing now. Um, I know that the DUI intervention program for the state of Georgia requires you to keep records um, in some sort of electronic record management system. So, is it HIPAA compliant? If you're providing links to things, make sure that they work. And then, of course, social media, I talked about that. Just, it's not a good idea to have your clients on your social media at all. And then when we talk about supervision and consultation, so what are the rights and the responsibilities of the supervisor, and what are the responsibilities of the supervisee? Making sure that your supervisor is trained and following the code of ethics. The supervisee supervisor relationship is protected. So, in order for the supervisor to divulge any information to anyone else, they would need a release of information from the supervisee. If there is a clinical crisis, what to do in that situation, the supervisor should be training you on what to do in a clinical crisis situation, and the supervisor would technically be in charge there. And what is the process for this? And then multiculturalism, making sure that, the supervisor understands that the supervisee may be of a different culture. And then they may be diverse. So you may have male and female, old and young, etc. Learning to work with the different diverse populations out there as a supervisor. It also talks about the boundaries between supervisor and supervisee. You guys are not friends. This is kind of like a counseling situation. So you don't want to have dual relationships. So setting clear boundaries. These are my office hours. This is when we will meet. This is what's required of you. The supervisor should be monitoring you, taking assessments of you, and treating you fairly. The supervisor should not be impaired, nor should the supervisee, and the client should be aware that the supervisee is under supervision and that the supervisor will be going over their sessions. So disclosing that to clients and disclosing to the supervisee what is everything, basically, the boundaries, what's required of them, etc. The supervisor should be making observation of the counselor, and the supervisor is the gatekeeper to your certification or your licensure. So they are monitoring you and making sure that you're not making errors that are affecting someone's mental health negatively. The supervisor should be educated, be current on their treatment and their education and what they're teaching. They should be doing evaluations on you that are fair and accurate. Again, with the dual relationships, there should not be a dual relationship between you and the supervisor. It talks about e-supervision, and I know some since COVID have started doing e-supervision. It talks about harassment. You should not be harassed by your supervisor. It talks about distance and termination, and the supervising relationship is not counseling. So you are not to use the supervision session as a counseling session. And then it talks about endorsement. And then we have principle 8, which is resolving the ethical concerns. So the code of ethics, endorsements, the decision making model, what is the proper jurisdiction, going through investigations, participation and cooperation, what happens if there's an agency conflict, or what happens if there's a crossroads, violations with and without harm, non-respondent people, consultations, and then retaliation. So all of that is in the code of ethics, and I really advise you to read through the entire code of ethics so you know these things. Principle 9, research and publication. So it's going to talk about participating in research, making sure it's consistent, it's independent, so you're not collaborating with someone that you're, you know, doing the research for. Um, Protecting the information, making sure the client's welfare is taken care of, providing informed consent to the clients or the participants in the research, and making sure that everything's accurate, the data is accurate. It talks about students, clients, their consent, explaining everything, talking about the outcomes, what's going to happen if you have to transfer these participants out. It's talking about diversity and verification of your data. And is your data available? And are there any errors in there? What to do about it? Then it talks about publication of your research, not stealing anybody else's research publications. Um, it talks about the ins and outs of e-publishing and advertising, making sure you're giving credit where credit is due, using student materials, submissions, and proprietary information. So all of this that we're going to talk about now is really important, especially for the clients, but you're going to be tested over this when you go for your certification. So it's important to know about these ethical words here. So when we're making ethical decisions, we want to use autonomy. Autonomy is allowing others the freedom to choose their own destiny. It's not what I want for the client, it's what the client wants for the client. So allowing them to be autonomous. Obedience. This is the responsibility to observe and obey legal and ethical directives, making sure you're staying in line with the code of ethics, staying within the law. Conscientious refusal. So this is the responsibility to refuse to carry out directives that are illegal or unethical. So, back in the 60s, the 50s and 60s, it was illegal to allow black and white people to eat in the same restaurant. However, it was unethical. So refusing to carry out that legal directive would have been illegal but not unethical. And then beneficence. So this is just helping others. Gratitude, passing along the good that we received to others. Competence, possessing those necessary skills and knowledge to treat the clientele in a chosen discipline, and making sure that you are current in what's working. So the theories, the techniques, the treatment modalities, is it working? Has it been shown to be effective? And then justice, fair and equal treatment, treating others in a just manner. Stewardship, making sure to use available resources in a judicious and conscientious manner and giving back. So, not overusing things, and making sure you're giving back. Making sure that we're honest and telling the truth. So, that's what fidelity is talking about, being true to your word, keeping your promises, keeping your commitments, making sure you're loyal and you're not abandoning the clients that you're working with. Diligence is working hard, being mindful and careful in the services you're delivering. using discretion, so that's going to be good judgment, honoring that confidentiality that you promised and that's required of you, and the privacy of others. And it's also important to improve upon self. So, self improvement is working on yourself, professional and personal growth, getting therapy for your own problems, making sure you're taking care of your professional responsibilities like your education and your certifications. Non malfeasance is not harming the clients or the interests of the clients. And then restitution, when necessary, making amends to those who have been harmed or injured. And then self interest, protecting yourself and your personal. So, the GACA Code of Ethics, this is going to be the same as the NADAC Code of Ethics, but you still have to sign and adhere to these different codes of ethics. So there are 5, and there's only 4 that I've listed here, but there are 5 different certifications as far as the GACA is concerned when you are getting your certification as an addiction counselor. And the first one is the counselor in training. So you have to have a high school diploma or a GED in order to get this, and then 20 hours of education. So this is going to include your telehealth, this orientation that you're taking now, ethics courses, multicultural counseling, and you have to have a signed contract with a CCS. So this is the easiest certification to get. Then this is good for about 3 years, and then you can move into your CAC1. You will have to take a test in order to get to the CAC1, but before you can even take the test or apply to take the test, you have to have a high school diploma or a GED and 180 hours of addiction specific classroom hours. So you can use some of your hours from your degree program if you're in a degree, or you can use continuing education hours, but you have to have 180 hours. And last I checked, every credit hour that you get counts in college counts as 15 credit hours towards, or 15 CEUs. So if you have a 3 credit hour course, then that's going to be about 45 hours counted towards your classroom time. Some of these are required face to face, and some of them you can do online. As far as supervision goes, you have to have 96 hours from a CCS, but you have to have 220 hours total. So 96 hours of those are going to come from a clinical supervisor. So meeting with that clinical supervisor once a week for an hour, 2 hours, whatever they require from you. And then you also have to have client contact hours. And so that's going to be about 2 years of full time work. The requirement is 4,000 hours. So you're going to have to work those 4,000 hours before you can even apply for the test, to take the test. And then if you pass the test after achieving all of that, then you will have your CAC1, and that is good for 2 years, and you'll have to renew that every 2 years with the continuing education units that you took during those 2 years. Then you have the CAC2. So this is you're going to have a 2-year degree at this point. You're going to have 270 hours of addiction specific classroom hours, 144 hours from a clinical supervisor, and 6,000 hours of client contact hours. Now, these client contact hours can be group, individual sessions, working on intake paperwork, um, treatment notes, treatment planning, any of the paperwork that you have to do with that involves intake planning, documentation, termination, any of those that fall under the 8 counselor skill groups, that's going to apply to these contact hours. So again, that's about 3 years of full-time work. And then to be a CCS, a clinical certified clinical supervisor, you have to have the CAC2 certification already. You have to have supervised at least 2 lower level CIT or CAC1 counselors for at least 2 years, have 36 hours of specific supervision specific CEUs, and then 2 years of supervision by a CCS that is supervision specific. I'm not going to go into each of the details for each of these particular certifications, you do have the PowerPoint, and all of this is listed on the application for the CIT, CAC1, CAC2, and CCS applications. So you can read through those to get an idea of what you're going to need for each one of the certification levels. So I will skip through each one of these, but you can read all of this on the GAC website, GACA website, which is gaca.org. It also talks about the items that you're going to have to send in. All of these are actually inside of the application, so it's not something you're going to have to go out and search for. Now let's talk about that counselor skill groups. In order for you to become certified, you're going to have some sort of supervision in each of the counselor skill groups. So you have to have a minimum of 15 training hours in each of these 8 skill group areas. So you have treatment admission, which is the screening, the intake, the orientation, the clinical assessment, ongoing treatment planning, counseling services, case management and referral, documentation, so this is reporting and record keeping, discharge and continuum of care, and legal, ethical, and professional growth. So in treatment admission, this is going to include screening, intake, and orientation. This is where you're going to interact with the client and determine, are they even suitable for your treatment program? You're going to obtain the information that you're going to need for admitting the client. So using the right assessments, the appropriate treatment, you want to make sure that all that data is collected. You want to orient the client to the counseling process, explain the rules and expectations, and you're going to also let them know what their financial responsibilities are. Then in clinical assessment, this is where we're going to get the data, synthesize it, interpret it, and figure out what does the client need? What are their immediate problems? Internal and external resources that could help the client in their treatment process. And then this assessment is going to form the basis for the treatment goals and the program that we're going to establish for the client. So just making sure that we're assessing the client accurately. And then ongoing treatment planning. This is not just a one-time thing. This is going to be kind of ever flowing and changing. It's going to ebb and flow as the client needs it to. So this is specific to the client. It's individualized. The treatment plan is going to address their needs and put them in the right place. So I'm not going to put someone with sexual trauma in an addiction treatment program, and I'm not going to put someone into a mental health program without first addressing their addiction needs. And it could be at the same time or one at a time. So in counseling services, this is going to be whether you're doing individual, group, family, crisis intervention, or client education. Here you're just trying to help the clients to change their attitudes, their beliefs, their behaviors into something more constructive than what they have been doing. So you're going to have to figure out what's the most appropriate type of assistance that you can provide. What counseling interventions are going to help to facilitate those changes in the behaviors, attitudes, and beliefs? And then which counseling services are going to be included in the individual, family, group, or crisis intervention counseling? Case management or referral services, this is going to include case consultations, interfacing with other agencies and professionals. You want to make sure that you're meeting the treatment goals that you've come up with the client. Consultation and case reviews by clinical supervisors. This is going to be important in managing that counseling process and making sure you're providing that quality care. Pardon the baby crying in the background. All right, so you want to make sure that you are just keeping the documents as they're supposed to be. So making sure you have the right forms, the right releases, the consent forms, all the records that are supposed to be in there, their treatment plan, their assessments, any group notes, any individual notes from individual sessions. You want to make sure that you're writing it down. Remember, if you don't write it, it didn't happen. I can't stress that enough. And then we talk about discharge and continuum of care. So this is going to involve the reinforcement of any changed attitudes, beliefs, and behaviors. Assessment that there are no other pressing needs, following up on that client status, making the appropriate referrals for any continuing services if necessary, assessing the adequacy of their support systems. Information on relapse prevention is essential here, making sure they have that information, making sure they're continuing in their self-help programs or other support mechanisms. And that's all provided in this termination process. So when you are learning about legal, ethical, and professional growth, you're going to learn about what are the federal and state laws that are going to control the counselor-client relationship. You're going to learn about adhering to the code of ethics. You're going to learn about self-education, continuing that education, growing personally, the dynamic nature of the therapeutic process, and how that's going to demand a clinical self-evaluation, monitoring yourself, and being self-aware. You want to make sure that in your training, you are taking courses for telemental health. You have to have 6 hours of telemental health. You have to have 6 hours of the CFRA, or what we call CFR 42, which is Confidentiality, Health Insurance Portability, and Accountability Act, which is HIPAA. Pharmacology, you have to have 15 hours of that, 15 hours of cultural diversity, and 3 hours of HIV/AIDS course. Just so you have an understanding of what the ASAM levels are. So ASAM stands for the American Society of Addiction Medicine. So the ASAM was founded in 1954, and it's a professional medical society that represents over 6,000 physicians, clinicians, and the different associated professionals in the field of addiction medicine. And ASAM is dedicated to increasing access and improving the quality of addiction treatment, educating physicians and the public, supporting research and prevention, promoting the appropriate role of physicians in the care of patients with addiction. You can find out more about ASAM if you go to www.asam.org. So let me explain what this level of care is. So the ASAM criteria text describes treatment as a continuum that's marked by 4 broad levels of service and an early intervention level. So early intervention would be something like DUI school or risk reduction school. So within these 5 broad levels of care, decimal numbers are used to further express the gradations of intensity of the services. The levels of care provide a standard nomenclature for describing the continuum of recovery-oriented addiction services. So with the ASAM continuum, clinicians are able to conduct a multidimensional assessment that explores individual risks and needs, as well as strengths, skills, and resources. ASAM continuum then provides clinicians with a recommended ASAM level of care that's going to match the intensity of treatment services to identified patient needs. So if you really want to fully understand these different ASAM levels of care and the appropriate matching of services to the patient's need, refer to the service planning and placement chapter in the book, The ASAM Criteria, Treatment Criteria for Addictive, Substance-Related, and Co-Occurring Conditions. It's 2013. But as you can see here, early intervention, so like I was saying, that's risk reduction. Level 1 would be outpatient services. Level 2 would be intensive outpatient or partial hospitalization. So 2.1 would be intensive outpatient services, 2.5 would be partial hospitalization. Level 3 would be residential or inpatient services, so 3.1 would be clinically managed low intensity residential service. Level 3.3 would be clinically managed population specific high intensity residential services. A level 3.5 would be clinically managed high-intensity residential services, and 3.7 would be medically monitored intensive inpatient services, and then a level 4 would be medication-assisted inpatient services that are intensive. I know that we're running out of time, but I really want to go over this alcoholism scale for you. So you can use this link here to get to this assessment. But it is a 25 question assessment for alcoholism. So it's scored 0 or 1. 3 choice items are scored 0, 1 to 2, and 4 choice items are scored 0, 1, 2, 3. In each case, the higher the value, the greater the dependence. And so the total range is going to score from 0 to 47. So the higher the number, the greater the dependence for. So you have this alcoholism scale, and this is how you can determine what level of care the client's going to need when they get their score. So if it's a 0, we're just going to give them some advice. 1 to 13, they're going to need a level 1 treatment, which is the outpatient services. 14 to 21, they could either need a level 1 or level 2. 22 to 30, they're going to need a level 2 or level 3, depending on how high it is. And then at 31 to 47, they're going to need level 3 or 4. It's going to be intensive inpatient treatment if they score really high on this scale. Then you have other treatment screening tools. So you have the CAGE. So you're going to ask them the letters of this acronym. Have you ever felt the need to cut down on drinking? So the C stands for cut down. The A stands for annoyed. Have people annoyed you by criticizing your drinking? The G stands for guilt. So have you ever felt guilty about drinking? And the E, have you ever felt the need to drink first thing in the morning? So the E stands for eye opener. So have you ever felt the need to drink first thing in the morning to steady your nerves or get rid of a hangover? You also have the MAST, the DAST, the SASE, and you have to be trained on how to use each one of these screening inventories before you use them. Again, if you don't write it down, it didn't happen. So there's many different types of ways, but there's 2 types of ways that we do notes. You have burp notes and soap notes. So burp notes, you're going to write down the behavior, the intervention, the response, and the plan, and you can see you're going to do it for each objective from the client plan. Soap notes, you write the subjective, the objective, the assessment, and the plan, and I've provided examples here for you that you can look on the PowerPoint. If you have any questions, feel free to email me, desiree.cochran@gmail.com. Make sure that you take the quiz so that you can get your certificate of completing this course. Please be sure to also fill out the evaluation, also located in the classroom. Thanks for joining me today. I know we went a little bit over, but I really appreciate you joining me and taking this course. Feel free to take any of the other courses available in our classroom.